Good afternoon. Um, so it's my pleasure to welcome you to yet another interesting session this afternoon during the 10th World Heart Summit. As noted yesterday and earlier today, we gather at a critical juncture in global health where the urgency of addressing cardiovascular disease has never been more acute. I often find comfort in knowing, oh, I need that. Thank you. I often find comfort in knowing that there are a myriad of organizations and actors out there that display a steadfast commitment to address the burning health issues of our time through their ingenuine approaches to deliver innovation and relentless work in service of humanity. This panel discussion will dive into one such example, the Cardio 4 Cities. Despite existence of ample evidence and best practices, CVD remains a burning issue globally, resulting in millions of people dying prematurely. I don't need to repeat that because we have been seeing it for the last 2 days now, that almost 21 million deaths, 32% of all global deaths, and more than 400 billion direct costs only in the United States, almost the same amount in Europe also, which will rise to 1,500 billion in 2050. And then there is the indirect cost that goes towards the risk factors as well. As we see through our World Heart Report that was published in 2023, we will see that there is going to be a significant increase in the cardiovascular risk factors as well as various diseases over time. Although the global progress against CVD is now flatlining, though the rates of CVD deaths are globally falling in the last 3 decades, but this trend has begun to stall and is at the risk of reversing. Now, if we look at the risk factors, we have seen that all risk factors are likely to increase, and there are yet another risk factors that we look at the PURE study that shows in the high-income countries, middle-income countries, and low-income countries, the paper that is from Dr. Salim Yusuf's group. You look at the novel risk factors, risk promoters, risk facilitators, quite like the air pollution, household air pollution, the low education, and that was presented by Anne earlier in the AI for cities as well. And look at the abdominal obesity, low physical activity, low grip strength, etc. So there is no one size that fits all and for improving the cardiovascular health. Every population is susceptible to different risk factors based on where they live and their lifestyles, whether that is having higher prevalence of tobacco and alcohol use and higher sodium intake or being more exposed to dangerous levels of air pollution and having lower levels of physical activity. This means that policymakers must look closely at the risk factor prevalence in their regions to fully understand what areas need more focus to get cardiovascular health moving in the right direction. The Cardio 4 Cities is a population health approach pioneered by the Novartis Foundation in scientific partnership with the World Heart Federation. While the initiative embodies a transformative vision for the future of urban heart health, Cardio 4 Cities has already convinced city health decision makers across several continents, mainly due to 2 aspects: its striking simplicity during implementation and its continued cost effectiveness when scaling. It represents a bold system-level approach to tackle the heart disease in urban settings. It recognizes that heart health is not solely a matter of individual choices or delivery of care. Instead, it sees cities for what they are, the engines of our economies and the hubs of our innovation. Accordingly, they can be the epicenters of health population. Enabling data-driven decision-making and unlocking the power of multi-sector partnership while guaranteeing full local ownership. The approach accelerates early detection of cardiovascular risk and optimizes the care management. Cardio here is just not for saying the heart, but it is an acronym. And the Cardio 4-City approach focuses on several key interconnected elements. That is, improving the quality of care, that's for C, ensuring early access to health services, the A, reforming policies with proven health benefits, the R, leveraging the data and digital technology, the Ds, and fostering intersectoral collaboration, that is for I, and ensuring the local ownership for the sustainable impact. So the Cardio 4 Cities is a multi-sector, data-driven partnership approach that improves the cardiovascular health in the urban areas. So there are certain core pillars of the Cardio 4 Cities, but its success hinges on partnerships. It requires city governments, healthcare providers, NGOs, the private sector, and communities to work together, breaking down silos and aligning their efforts towards a common goal. As you can see here, and yesterday this was presented effectively, that if we go and start working at the city level, we will be able to make a difference. It was suggested that if we are able to bend the curve for the cholesterol in the cities, we probably would be able to increase the lifespan without having a heart attack by about 30 years. On the other hand, Dr. Tom Frieden yesterday showed that if we start to work on the blood pressure control and the numbers that he presented to us, that there would be a reduction of approximately 50 million deaths over the next 25 years. So, if I think there is one slide which is yes. So what is most striking is that the approach yielded measurably significant results within relatively short time frames after implementation, with blood pressure control rates that tripled in the multiple cities, all while stroke hospitalization and heart attack rates went down by double digits. So in January of 2025, there was a Davos Declaration where it was proposed that we would like to have this as a scalable implementation, and we will try to reach out to a large number of cities over the next few years. And repositioning cities we will be using as catalysts for heart health through such rapid progress, which is needed more than ever, especially given the prospect that nearly 70% of the global population will be residing in the cities by 2050. Davos Declaration was made early this year, as I said, with a resolve to scale the effort to benefit as much as possible. By now, Cardio 4 Cities has reached over 40 million people and has proven to be impactful and scalable in different geographies around the globe. The approach presents a transformative opportunity for the cities to reimagine cardiovascular health for the future generation. And lastly, we recognize that tackling the cardiovascular diseases requires a bold, system-level approach. We cannot afford to continue with a fragmented, reactive model of care. The scale of the challenge demands a fundamental shift in how we think about and address heart health. The World Heart Federation is proud to be a key partner to the Novartis Foundation in scaling Cardio 4 Cities. Our mission is to unite the global cardiovascular community to reduce the burden of heart diseases and stroke. We believe that Cardio 4 City aligns perfectly with this mission. It has already become inspirational to multiple sectors around the world, and people have started using Wolrd for various initiatives. Look at cardio for communities, cardio for country A, country B, and whatnot. So let us dive into our panel discussion here, for which I invite Ann Arts to moderate the session. Ann Arts is head of the Novartis Foundation, and she'll be moderating it for us. We have Professor Gregory Hunt on your right. He was the former Minister for Health and Aged Care in Australia. Thais Yunkera, the CEO of Umane Foundation. I have John Shunby, who is the Global Chief Medical Officer for Swiss Re Foundation. And we have had a brilliant relationship as well as discussions with Swiss Re when we were in Davos also. And I actually told that I was going to name my grandchild, if it is going to be a daughter, after her. And Professor Bert Weiss, he is Faculty of Medicine in the Catholic University of Leuven, Belgium. So, Anne, would you take it from here?
Thank you very much, Jagat, for this wonderful speech on Cardio for Cities. We are truly honored to have you and the World Heart Federation as our scientific partners. Thank you very much. So, as everybody's been nicely introduced also by you, Jagat, let me start by asking you a first question, Greg, if I may. How do you think we can motivate governments to empower their city leaders to take this kind of action, coordinated action with different partners to address cardiovascular disease and become the beacons, the blueprints of population health in their settings? Why do we need to have cities setting that example for the rest of the world? And how do you see Cardio for Cities as an example that is pragmatic and simple enough to do so?
Sure. So thank you, Anne and everybody. If I may, I might start with two of our earlier speakers. Before lunch, Professor Sidney Smith talked about the challenges in North Carolina of giving cardiac care during COVID. But he understood that because there was an unprecedented mobilisation. That communicable disease took 20 million lives on the best estimates from the World Health Organization. And then over lunch, during the fireside chat, Jagat was interviewing Hyvel, who was a patient survivor of a cardiac arrest. And she said that statistics in terms of mortality are a cry from the grave. Every year, we have approximately 20 million lives that are lost to CVD. Every year, we have the equivalent of a COVID pandemic of lives lost. Each year, every year, ongoing. And I think the challenge for governments is that that is not understood. So the challenge is that there's not a full awareness, understanding. In part, it comes down to the nature of cardiovascular disease. In part, it comes down to the awareness, but also to the voices which are not as prominent in cardiovascular as they are in cancer, nor in the communicable space. Fear rules communicable. The voices of the patients and the survivors and the slow train of cancer gives immense power. And so the first thing is to have those voices. And how do you have those voices that have an impact on government and on population? The city becomes a prime motivator. And so what is cardio? Jagat summarised it, I think, beautifully, but in essence, to take an entity and to bring the parts together. And what do? They're involved in education. They're involved in widespread screening. They're involved, therefore, in treatment, whether it's lifestyle modification or access to medicines. And it's focused in particular on lower socioeconomic countries and cities and lower socioeconomic groups, be they high income or lower income countries. And then you say, well, what does it actually mean? What do I do? What's different here? In Brazil, it's about having screening programs at football matches, in women's health groups, in women's knitting or other forms of groups. In Ulaanbaatar, it's about making sure that you have men who are involved in different community activities or in age groups have access on site, in place, to screening in a way which they would never otherwise access. So that's how governments can help. They can help bring those programs. We have the Shane Warne Foundation in Australia. I think, Jagat, you referred to David Beckham. Well, Shane Warne was the Beckham of Australian cricket, and he lost his life to cardiovascular disease, a sudden illness, not diagnosed, not expected. But the family has taken that to have programs at test matches, at cricket matches, where Aussie men who are, perhaps unlikely to be screened, go and do the screening on site, and it's taking the program to the people. So then you say the last thing is, what are the outcomes? Those figures of a 13% reduction in stroke, a 12% reduction in heart attack in Sao Paulo, likely to be updated with improved data again in the second round, of a 3 to 6 times increase in treatment for hypertension, are real human outcomes. So education, screening, treatment, lifestyle modification all come together by focusing on lower socioeconomic groups in urban environments, large numbers of people who are most vulnerable, where there can be the greatest difference. That's what this program is about. I think it's 40 cities now, 40 million people. We're aiming to get to 150 million people, which ties in with the World Heart Federation and the summit's goal of 500 million people having interventions. This is a trial program at global scale, and that's what's important. It's about saving lives and protecting lives through practical interventions.
Thank you very much, Greg, and very powerful, your message of bringing the services to where people are. That's what we have to do, and focus on those who otherwise wouldn't get to those services. Very nice. Thais, can I move to you, to Brazil? So Thais is the CEO of the Humani Foundation, the first partner we had in Brazil, the first not only partner in crime to decide on the further design of the whole initiative, but also the first co-funding partner who dared to step in the boat with us. And we are extremely grateful to you, Thais, because you set the example. And by now, we created together with you a whole coalition in Latin America, together with Swiss Re Foundation as well, and many other players to make it feasible to scale this approach across the region. So why would you think that we have to come together as philanthropic organizations or private sector players to scale a proven city-based initiative like this? And what kind of lessons would you say are most important for all the others here in the audience to hear from this coalition?
Oh, thank you, Anne, for the invitation and for the opportunity to be here. So first, we live in a country where 1/3 of the population are in the big cities, and this is around 70 million people. And although we have a public health system that is universal and is designed to be coordinated by the primary care, we know that things are not always like this. And care is very fragmented, and we also have 1/3 of the population in Brazil with no access to primary care. So this initiative is so important in terms of, by the time it's structured, it also improves access with the public institutions. And I think that this was one of the key things, first to establish the program when it first started in São Paulo, Brazil. And now that it's expanding to other municipalities in Brazil, this is very important to engage the public leaders and to engage on the political side as well to improve the access to primary care there. Yeah. And one other thing that I would consider is that besides this importance of leadership as key, to identify where you need to work and where interventions could succeed, This is, I think that this would be the first thing when you decide to establish and to implement something in a big country like Brazil, because so big and so I think diverse and also unequal country, you have very different conditions when you are implementing this, and you can say that your zip code can determine your health outcomes, and when it comes to cardiovascular and chronic diseases in a context like this. So first thing I would consider is to go somewhere where you have leadership on the political level, and you have public institutions, and you have government, I would say secretaries of state, and also mayors that are committed to that. Because without this, in a setting like ours there in Brazil, you cannot even start to work. You can make better choices when defining the regions where you're going to scale and to implement. Second thing that Anne mentioned, the importance of the coalitions and the role of the civil society. Because without that, it's the process to bring innovation and also to test and to scale innovation, they will not happen the same way that we saw there and that we're seeing with cardio and now many different places and many different regions of the world. So having a well-established governance between actors of local civil society, and cardio is now able to do this in a global level. This is so important, and we are also thinking that to achieve the impact we want, we also have to do something like divide and conquer. You need to establish different goals for each institutions, and you need to have clarity of what they're doing, of what their value proposition, and what are their final goals. You cannot simply have a lot of civil society institutions working together and overlapping their actions. So after some years of implementation and having something that became a public policy in São Paulo, that is the Cardio Initiative, we are now at a stage where we need to identify the different partners and to establish specific goals and specific ways of supporting the initiatives for each one. We need to combine this and not only to just have something, each one doing what they want to do. And third thing I would say is about data. Data is key to succeed in the implementation and the results, and also to sustain legacy. When we don't have the commitment to first integrating data and then to generating the key indicators that you need, you still don't have the conditions. So I would put this identification of whether the institutions and the regions, if they have the conditions and the ability to work with the data that is needed to really provide something that is integrated and that is sustained, I would put this in the beginning of the process. When you identify a political leadership or a region, you also need to identify their condition to work with data. I would say these three things. So civil society active and engaging in governance, data, and the quality of the political leadership.
Thank you, Thais. Really important, and the balance to find between the top-down buy-in of leadership, but also the involvement of the people and the civil society into the process, and having clear agreements in a strong governance and good data to monitor our progress. It's all in one go. You mentioned that. So, John, if I may ask you, you are in fact one of our second partners stepping in the boat for us to replicate and scale cardio for cities throughout Latin America. You are the Chief Medical Officer of Swiss Re, the company. It's your foundation stepping into this with us, but can you tell us why is it important for you and your company to bring different sectors together in cardiovascular disease programs like this? And why is the reinsurance sector interested in this? Because I would like you to convince other partners to come on board.
Thanks, Anne. So Swiss Re is very proud to be part of this, and we're really proud of the outcomes. Lives have been changed. And our vision is to make the world more resilient. And generally that implies financial protection for people. But in this case, of course, we're making them more resilient through improved health. So there have been a lot of really big advancements to improve longevity. And that's really important to a reinsurance company, where the bulk of the protection is around mortality risk. But we have more risk than that, and that is we pay for certain events. So we pay for morbidity, disability insurance, critical illness insurance. And so it's not just about longer lives, it's about longer, healthier lives. And it's really compressing that morbidity at the end. And we know that high blood pressure related to cardiovascular disease and strokes is a really big driver of that morbidity as well. We've seen a lot of slowing mortality improvements over the last probably about 10 years pre-COVID, where populations are not getting older as we predicted they would. And that's a real problem when you have very long-term guaranteed products like life insurance products. And for us, we're somewhat agnostic around the causes. We don't look at it in a siloed approach. We're not aligned to the pharma industry. We're not aligned to the food industry. We're aligned to no industry, really. All we want is our policyholders to live longer. And so we really stand back and look really holistically at everything. And we believe that the catastrophic metabolic ill health epidemic that has overtaken the world is a significant driver of this. We've heard a lot today about metabolic health and insulin resistance. We believe insulin resistance is probably the key driver. One of the gentlemen earlier in the session today mentioned that inflammation happens many years before your coronary artery calcium scan shows some calcification. And similarly, insulin resistance, I believe, happens many years, if not decades, before the downstream effects. And the downstream effects are really all the non-communicable diseases. And so controlling blood pressure, which we know is a significant risk factor, is really, really important to us. And then maybe just finally, we've looked at what Jack shared, the costs of hypertension and cardiovascular disease. We know the costs of diabetes. And while these are very big numbers and everyone's worried about healthcare costs generally rising, for me it's also about opportunity costs. If we can reduce spending on these diseases that really should be, inverted commas, preventable or controllable, then really we can start helping people with other conditions, rare cancers, rare diseases that are very expensive to treat, but in many countries, the systems essentially cannot cover those. So that opportunity cost, I think, is also something we need to keep an eye on. Thank you very much.
Wonderful. I cannot agree more. And this is absolutely, if we can save on the space of cardiovascular health, we could help some of the LMICs to address cancer, for example, where many of those diagnoses are death sentences that don't have to be. So definitely very important. This brings me to you, Bert. And Bert, you are leading the cardiovascular population health management approach in Leuven, the city of the University of Leuven, obviously, everybody knows, as I'm coming from there too. But your approach is very interesting because you take it as a verb, the population health management. You have to work together with lots of players from both the community and the decision makers and the health providers. All of them have to be together in that kind of collaboration. And you make it a condition sine qua non that data is at the center, and you establish easy-to-use tools for all these different players to use and improve their performance and the progress towards the targets you set yourself. So I would love you to explain a bit about what you are developing as they are these tools, and the whole approach is going to be relevant for so many other settings in the world.
Thank you very much. Thank you very much for the invitation to be here. and the opportunity to bring the story from Leuven. Well, besides an academic, I'm also a general practitioner working in daily practice. And as has already been said today, as healthcare providers, we are currently mainly working in a reactive way, running behind the facts day in, day out. In order to face future challenges in healthcare, we need to try to make a shift from that reactive to more proactive care, in which we try to identify patients at risk before something bad happens, especially in those who have difficulties finding access to healthcare. Well, population health management is a strategy, is an approach that could help us to realize this shift from reactive to more proactive care. And central in population health management is quintuple aim. The quintuple aim indicators that are being collected, data about quintuple aim indicators that can drive this population health management strategy. However, in Belgium, there is a lot of data that is lacking still. And furthermore, a lot of data is also fragmented in Belgium available. So not in a centralized way or very difficult to bring together. And therefore, we developed two strategies in order first to collect data in primary care, especially in general practitioners and in pharmacists. And second, to bring together organizations that are able to gather data on quintuple aim indicators. Well, the first strategy, trying to collect data in general practice, we developed an instrument that we called the barometer. And it's basically an instrument that is based on audit and feedback. So we start from standardized, automated queries inside the electronic medical record of healthcare providers, like general practitioners. And then aggregated data, or sent once every 6 months, for instance, from these practices to a central platform. So the individual patient data remains inside the EMR, but only aggregated data is sent. So we created a federated data network. And like this, we give also from the central point feedback to these healthcare providers so that they can try to improve the quality of their care and the registration of the data to try to increase the quality of data, which is key, of course, if you want to do something with that data. And for instance, to give you an example, we have now a diabetes barometer that is running in Belgium, in which 11,500 GPs of the 12,500 that are actively working in Belgium are participating in this system. And so 90% of the GPs are participating, and they are taking care of 10 million Belgians. And so this instrument is nationwide, covering primary care and our population in Belgium. And currently we are also developing the barometer for atherosclerotic cardiovascular disease, so that we can also upscale this in the following months to monitor atherosclerotic disease in primary care. But of course, then you have data on population health and you have data on the quality of care, but that's not covering quintuple aim yet. So therefore, in the second step, we create an open network organization bringing together universities, data suppliers like our national health insurers, like also the National Scientific Organization, and also pharmacists, for instance, that also collect data in order to try to capture these quintuple aim indicators. Now, at the request of the federal government and with the financing from European recovery money after the COVID-19 epidemic, we designed, together with our partners, a mock-up dashboard on how a population health management dashboard could look like, based on evidence, but also based on focus groups in which healthcare providers, policymakers, health managers, population managers were represented to give insights in what they really need to try to manage a population. There are three characteristics of this population dashboard, which is first that you need to be able to explore the population. Second, and that's very important, to be able to stratify the population and to plan your actions that you're going to do, because as we know, of course, not everybody needs the same intensity of care in the healthcare seeking population. And third is a research community, because we want to offer, of course, also data analysts and more experienced health managers to dive into the data and to test and to explore new hypotheses to help to drive also population management. And right now we are making the first version on atherosclerotic cardiovascular disease, where we brought together data from general practice, from health insurers, and also data on the social determinants of health, and where we explored the association between atherosclerotic disease and social determinants of health, in order to make that pyramid with people with and without ASCVD and with and without socioeconomic vulnerability.
Thank you very much, Bert, and that is a real difficult exercise. We are at the same stage in our AI for Healthy Cities program, where we are stratifying populations and identifying those determinants that have to be added to the clinical determinants. So it's not easy, yeah, but that's the way we have to move forward. I'm happy to hear that. Jagat, after your beautiful introduction on Cardio for Cities, and again, we are really thrilled to have you as our partners, and specifically as our scientific partners, to make sure that this approach becomes a continuously learning approach that is always improving itself. What did convince you about the scalability of this simple approach, that it is Cardio for Cities is a winning strategy to implement what we know needs to be done and what doesn't get done? So what convinced you that this can bend the curve on cardiovascular disease?
So our objective, as you know, is the cardiovascular health for all, everywhere. And there could not have been anything better, because the results were obvious from the 3 cities, as Professor Hunt just told us. 3 times better control of hypertension. Just one simple change resulted in 12% decrease in strokes and 30% decrease in heart attacks. And we are just talking about hypertension. We are talking about one, which is obviously the most important risk factor. You have seen the cholesterol, which we can also reach out to very easily. And the reason being that now we have got the longer acting drugs, which are becoming available both for cholesterol management as well as for hypertension. There is a possibility that there is a combination of such small inhibitors of mRNAs are coming. Would I be able to give it to all? Rather than going for secondary prevention, would I be able to use them for the primary prevention? Can we apply it at the level of the pharmacist, quite like I do it for the flu vaccine? And that is the trial that we are starting in Texas now. And so that should become, because, I mean, these are the drugs which are without side effects. And normally, what we have been trying to do is that we use the drugs which possibly can give the side effects, right? So rather than that, we are now bringing in much benign medications, which can be given once a year, and you are able to control the major risk factor for the disease. And then we can look at multiple places, and then we can create the approach which could be scalable. And that is what we have been discussing with you, that every city that we include should bring in something novel in there. For example, we are using this approach. Somewhere else you can use something else. For example, the Beijing, 2008, when the Olympics were there, at that point in time, they had removed all the industries and all the fossil fuels and all, everything from that area. And you saw the way there was a significant impact on the air pollution as well as the resulting coronary disease and the respiratory diseases and all. Not only that, in Wuhan, they had demonstrated that even day to day or hour to hour differences after the air pollution would change, you would have a difference in the emergency room admissions for the acute myocardial infarctions. So if we start looking at various places, and the beauty of this approach is that you try to identify in every city based on the data that are already available, we exploit that and try to develop an approach which should be specific for that city. And then learning from that city, can we really multiply it? What better can be for World Heart Federation? And that is the reason that we instantly got excited about it, and here is the partnership. Thank you.
Thank you, Jagat. And yes, it's true. Every city gets a tailored cardio for cities. And in the meantime, in fact, it does address hypercholesterolemia and diabetes as well. We increase to all of the main risk factors. And I think you gave us just the hope that this ambition I expressed in my previous talk about the potential to eliminate heart attacks by the convergence of the scientific innovations, these siRNAs, but also the weight control drugs now, and the technology innovations, that convergence can help us eliminate heart attacks for the next generation. We want to do that with a city who wants to step in the boat and show that it's feasible. So thank you, Jagat. I'm afraid our time is almost up, but maybe in one sentence from each of you, and starting with you, Greg, maybe, what is your takeaway of this panel? Are you still as enthusiastic as you were in the beginning?
Yes, still as enthusiastic, no loss of that. Practical programs. What is this about? As a policy maker, something that grassroots people, often of the non-dominant language in a community, can understand. Go and get screened, says spouse to spouse. Take the opportunity. And something that policymakers who are not clinicians can also understand, that heart disease, and I use the term heart because policymakers often don't understand cardiovascular. Heart disease kills 20 million people, and in Australia that's a proportionate amount. And we can deal with it through programs in the same way that we have cancer screening, we need our cardiac screening.
Wonderful. John?
I think one of the reasons that this is successful is that we're not just throwing money at a problem. I think by being local, by finding out what the problems are in a specific city, by listening to people, by being flexible. I think in the end, by making sure it's local and it's owned by the city, and finally, I think the behavior side. So often, right, there's a drug and you prescribe it, but the behavior of being compliant, the behavior of the patients, but also the health providers, right, of doing it in a ordered way. I think all of these boxes get ticked, and I think it's just fantastic.
Thank you. Bert, do you want to add something?
Yeah, I think that we can collect a lot of data. There is already a lot of data. We can make nice and beautiful dashboards. But at the end of the day, the question is this data been put into action? So we really need also living labs where new approaches in using that data are being tested. And therefore, I'm happy that in Leuven we really have this intertwining in between policymakers, universities, healthcare providers, and community organizations that are all working together in trying to put that data into action.
Exactly, and that's absolutely the same approach as in any cardio for cities. Huh? Dice?
Yeah, I would just say that. Yeah, I would just say that I leave this panel really looking forward to bringing more integration to our work in all senses. The data that you just mentioned, and the way that we communicate with the health professionals that are there on the primary care doing their work, in the way that we define and that we combine goals with the public institutions, and the way that we work together as civil society to tackle this. So thank you for the opportunity.
Fantastic. Thank you very, very much. A warm applause for this fantastic panel, please.